Hello, I'm Ted Feldman from Chicago, here with Professor Martin Bergmann from Hamburg, and we're going to discuss the role of left atrial appendage occlusion for patients with atrial fibrillation. And I think the first point is defining why left atrial appendage mechanical or device occlusion has any role in an era where we are really inundated with new oral anticoagulant therapy. So why do we need an alternative?
Well, I think for the last couple of years we've seen that many patients have profited from the introduction of the direct oral anticoagulants, but we see more and more patients who cannot take them for a long time. These are patients that have regularly surgery where they need to stop it and then start it again. We have patients with acute coronary syndromes, which we would like to take on platelet inhibition, but we can't because we increase the bleeding risk. And there are patients that still bleed even with the new oral anticoagulants, because in comparison to warfarin, bleeding is not decreased regarding gastrointestinal bleeding and other things.
So I've also encountered some individual patient situations that are driven much more by lifestyle choice. For example, a young man, CHADS 1, low risk, whose whole life was martial arts. And getting him off of oral anticoagulants and treating him with a device restored his life. Another young man, his whole life is about skiing. So getting him back out into his avocation was critical. And another in an older man who in his retirement was traveling to remote places in the world and feared terribly having trauma and being in Central Africa or somewhere in the wilds of South America and not being able to manage that. So I think we can go beyond the strict medical boundaries when we consider some of the value of a non-pharmacologic alternative.
I would fully agree. I think the beauty is that for all these patients that for one or the other reason cannot take oral anticoagulants for long term, we do not need to go back to aspirin, which actually leaves them with an excessive stroke risk, but we can now go for an interventional procedure which is easy to perform in experienced hands, and where we now know that we have good clinical results and randomized data to support the strategy.